baby is born with congenital syphilis, how do you identify the histopathology on the placenta? The key words that you're looking for over here are abscess-like foci of necrosis surrounding the umbilical vessels. If you also have them being small for gestational age or an atypical delivery when they're born preterm, these are also things that go hand in hand with that. They may also describe the uterus as pale and enlarged or edematous. I shouldn't say edematous, just enlarged. Not the same thing. Rhesus incompatibility will also cause a pale and enlarged placenta because of the fetal anemia. However, there will not be umbilical cord inflammation with abscess-like foci of necrosis. You have a patient who had some sort of respiratory viral illness, and then 2 weeks later, all of a sudden, they have acute abdominal pain, severe. They're hypotensive. What do you think happened? Possibly a splenic rupture, right? So, what do we do now? First thing you need to do is stabilize him. He has hypovolemic shock. You need to get him volume resuscitation. Get him hemodynamically stable, all right? Start doing serial CT scans, seeing how the spleen is responding to the volume resuscitation. If the patient continues to be hemodynamically stable, then you start to consider doing an XLAP and splenectomy. But we try to preserve the spleen as much as we can. Okay, we try to preserve it as much as we can. Surgeons have a grading system to determine whether the spleen can be saved or not based on the imaging. If you have a normal distribution, 1 standard deviation away from the mean is 68% of the data. 2 standard deviations away from the mean is 95% of the data. And 3 standard deviations away from the mean are 99.7% of the data. Preventative medicine strategies are described as being primordial, primary, secondary, tertiary, and quaternary in terms of their level of prevention. Primordial prevention is defined as the prevention of risk factors themselves. It consists of preventing the conditions in which these factors are observed to develop. Primary prevention is action taken before a patient develops the disease and is targeted at preventing occurrence of the disease itself. Secondary prevention is defined as an action that halts or delays the progression of a disease at its initial stage and prevents complications. Tertiary prevention is used when the disease process has advanced beyond the early stages and is defined as taking all actions available to limit impairments and disabilities. Quaternary prevention is a set of health activities that may mitigate and or limit the consequences of unnecessary or excessive intervention by the health system. What is the first treatment intervention for GERD? Don't try to do any endoscopy or any acid level measurement or anything like that. Leave it alone. Give them acid suppression medication. That's what you do. Give them a trial of PPI. All right. See if that works. If it doesn't, then you can go on to talk about doing other things. But that's the first thing you're going to do. Okay. However, if they have GERD with alarm features, then you do an endoscopy. What are these alarm features? Dysphagia, adenophagia, weight loss, anemia. They might have cancer. We can also consider endoscopy if they don't have alarm features, but they've had long-standing symptoms for greater than 5 to 10 years. Why? Because this is a risk factor for Barrett esophagus, and if that's the case, we want to see that. Yes. Thank you very much, darling. All right, we got glucose and caffeine on board now. The attributable risk percentage describes the percentage of disease in an exposed group that can be attributed to the exposure. Sometimes it's described as the percentage of disease in an exposed group that could have been prevented by eliminating the exposure or the risk factor. How do you calculate it? The difference in risk of disease between the exposed group and a non-exposed group divided by the risk of disease in the exposed group times 100 gives you the percentage. Beautiful. Guy comes in intoxicated from alcohol. His blood pressure is starting to drop. He's 100 over 50. Pulse is 110. He's been vomiting up blood, bright red blood. What's the first thing you got to do for this guy when you come in? ABCs, right? So give him the fluid resuscitation, yes, but keep in mind his Glasgow Coma Scale. If he's unresponsive, or has a very low Glasgow Coma Scale, right? Let's say he's, not responding verbally to you at all. You have to do endotracheal intubation because this guy has a big risk for aspirating on his own blood. What do you want to do after you start to get him hemodynamically stabilized or giving him fluids? What do you want to do then? How do you start managing these esophageal varices that he's coming in for? You give him intravenous octreotide. Let's say his platelets are down. He has an elevated INR, just an elevated INR. Albumin is low, 2.8. Anything else you want to do for him? Where are the platelets at? 70,000. Don't give him any platelet transfusion. Don't give him any packed red platelets. Sorry, I got distracted. Don't give him any platelets. You give platelets when somebody's below 50,000. All right. Albumin, leave it alone. He's an alcoholic. INR 1.5. Cirrhosis commonly causes elevated INR due to impaired coagulation factor production. However, this may not represent the true bleeding risk because it only reflects procoagulant pathways. Albumin can be administered in patients with cirrhosis who have volume depletion and acute kidney injury because it can increase plasma oncotic pressure, right? However, it has no sustained impact on the serum albumin level. Once you discharge this guy, make sure that he takes home a non-selective beta blocker. Non-selective beta blocker. Nadolol, propanolol, carvedilol. Prophylaxis against future variceal bleeding. If those non-selective beta blockers are contraindicated, what do you do? Endoscopic band ligation can be performed on the non-bleeding varices to prevent future bleeding. Sydenham chorea is one of the major manifestations of acute rheumatic fever and is the most commonly acquired chorea in children. How do you recognize it? Well, in the history, you're going to have a couple of upper respiratory infections that came and went. And when they present with Sydenham's chorea, it's going to be emotional ability, decline in school performance. These are the earliest manifestations. After that, we start to see actual neuromuscular manifestations of distal hand movements, facial grimacing, feet jerking. The movements are typically described as irregular and rapid. They have decreased strength throughout all their limbs. The relaxation phase of the patellar reflex is delayed. There's pronator drift. All these things. You may do a heart exam and hear 2 out of 6 holosystolic murmur at the apex. All these things are telling you that this person has acute rheumatic fever. Peak incidence is in ages 5 through 15, and it's twice as common in girls. Let's go through the major Jones criteria just for completion's sake. Joints, carditis, nodules, erythema marginatum, and Sydenham chorea. Minor Jones criteria: fever, arthralgia, elevated ESR and CRP or CRP, prolonged PR interval on ECG. Remember that these criteria are used to diagnose acute rheumatic fever. You either need 2 major criteria or 1 major and 2 minor criteria. Remember that osteoblasts do not blast the bone to pieces. They actually build the bone up. Osteoclasts are the ones that crack and crash and clast the bone and destroy it. Okay, they're the ones that are activated with the autoantibodies produced by the B cells in multiple myeloma. In a woman who is pregnant and gets Lyme disease, do you have to worry about anything harming the fetus? If she gets adequately treated for 14 to 21 days with oral amoxicillin and cefuroxime, no, there's no data to show that there's an increased risk of damage to the fetus. Let's review the difference between Mobitz type 1 and Mobitz type 2 AV blocks. So these are both second degree atrioventricular blocks. Type 1 is when you have the lengthening, and then drop, right? Continuous lengthening of the PR interval with the sudden drop of the QRS that doesn't follow. Essentially a non-conducted P wave. Type 2 has regular PR intervals. It just drops suddenly. The QRS just doesn't follow. Okay? So, what's the difference between the two in terms of their rate of progression to complete or third degree AV block? Mobitz type 2, okay, the one where there isn't the longer PR interval, where there's just a sudden drop, okay, in the QRS, that one has a much higher rate of progression to third degree AV block, okay? So when you find a Mobitz type 2, you need to give the person a pacemaker. Don't let them go anywhere, okay? Now, hold on. Let's take a step back further. We give them a pacemaker if we cannot attribute the cause of the AV block to something reversible, such as pharmacologics, hyperkalemia, or ischemia, okay? Let's say you're in a situation where you are highly suspicious of ischemia being the cause to this AV block, and you want to do further testing for ischemia, such as a stress test, okay? You can't do a stress test unless that person has a pacemaker first. So what you can do is you could put in a temporary pacemaker, do the stress test, see if there's some sort of reversible ischemia that can address the AV block, and then you go from there, okay? Let's say you have a study, you have 2 intervention groups, and you lose a bunch of people throughout the study, okay? People don't follow up, people don't comply with the intervention, whatever it may be. But with the people that did stay behind, that did follow the full protocol, you have results that are encouraging against your null hypothesis, okay, saying that the intervention was significantly effective. What do you do in this situation? Do you just take that data as is with the people who finished the whole protocol, or do you do something else? You're going to do this something else. The something else is called an intention to treat analysis, where basically what you do is that you include the people who dropped out of the study or who did not comply, and you attribute their essential non-compliance or attrition to the intervention, okay? And what this is going to do is this is going to give you a more conservative estimate of the effect of the intervention, because what if some of these people dropped out because the intervention that you think is so great was actually not so great for that person, and that's the reason why they couldn't comply? If it was so great for them, then why did they leave? Why did they stop doing it? You have to ask yourself that question. So in this kind of analysis, you're going to treat their dropout or their non-compliance as an effect of the intervention to give a more accurate measurement of the experiment. The gonadotropin secreting cells of the pituitary gland secrete luteinizing hormone and follicular stimulating hormones. They are dimeric hormones that consist of an alpha subunit and a common alpha subunit and a different beta subunit. When gonadotropin secreting cells become dysfunctional, they secrete just the common alpha subunit. What this is going to look like is the body's not going to recognize any luteinizing hormone or FSH in the system. The woman is going to become amenorrheic, okay? And then when you go and measure for the alpha subunit, it is going to be markedly increased, okay? In addition to this, let's say the person has blurry vision, galactorrhea, headache. They have a tumor, a pituitary tumor, okay? Now, you may get the prolactin and the prolactin is elevated, okay? Normal prolactin levels are 5 to 20 nanograms per milliliter. What if it's 50? Don't believe that this is a prolactinoma, okay? What I told you before, that alpha subunit is up, okay? FSH and LH is low, okay? This is not a prolactinoma. Prolactinoma causes prolactin levels above 200 nanograms per milliliter, right? This is a non-functioning gonadotropin adenoma. Non-functioning adenoma. What are you going to do? Cut it out. Transphenoidal pituitary surgery. All right? If it was a prolactinoma, what would you have done? Carbergoline, right? Dopaminergic medication, carbergoline. You have hypovolemic hyponatremia. So there's low serum osmolality. And usually when there's low serum osmolality, the body will decrease the secretion of anti-diuretic hormone so that you can get more water leaving and increase the osmolality with time. However, this is hypovolemic hyponatremia. Whenever the body is in a situation where it has to choose osmolality over volume, it's always going to choose volume over osmolality, okay? So the body's main priority is to restore volume before restoring osmolality. So it is going to increase the secretion of anti-diuretic hormone in an attempt to retain volume. The problem with this, as you can imagine, is that if you retain water, close off those aquaporins, then you are going to, yes, increase the volume, but the hyponatremia will become worse, okay? So what do you do for a patient that comes in like this? Well, you want to restore their volume status. You want to use isotonic saline. However, you need to do it slow. the body can very easily respond to that increase in volume and start to overcorrect the hyponatremia by abruptly decreasing ADH and facilitating a large volume water diuresis. If this happens, you'll see that the urine output will increase very rapidly over a short period of time, and likewise the serum sodium will increase very rapidly over a short period of time. Your goal should be to increase the serum sodium level 4 to 6 milliequivalents per liter over a 24-hour period. Anything faster than that is too fast. If the patient has had hyponatremia for a long period of time, it's been chronic, then they can be at a very high risk of developing complications from this rapid correction, such as osmotic demyelination syndrome. Let's say you have a patient who is hospitalized after a knee replacement and they develop sudden onset of chest pain, shortness of breath on post-op day 5, and you see some tachycardia, and they've been on heparin for the past 5 days. What are you suspecting? Pulmonary embolism. You do the CT angiogram, you see the pulmonary embolism is there. Then you draw a CBC and you see that their platelet count has dropped to 45,000, where before, when he first came in, it was 170. So what's going on here? This is type 2 heparin-induced thrombocytopenia, HIT. Okay. HIT should be suspected whenever you have a platelet count that falls greater than or equal to 50% from baseline 5 to 14 days after starting heparin. If you have new onset unexplained thrombocytopenia, or if you have thrombosis in a patient who's recently treated with heparin, what's the first thing you do? Stop all heparin products, including things like enoxaparin, right? The low molecular weight ones. Next thing you do, obtain confirmatory laboratory testing. Do the serotonin release assay. You're not waiting for the results of that, okay? You're going to continue on and you stop the heparin products, but you have to address the fact that this person has a thrombus, right? And so you are going to give them direct thrombin inhibitors, argatroban, okay, or fondaparinux, right? Even if they don't have a thrombosis, you're still going to give this, okay? Because in type 2 HIT, the risk of developing thrombosis is very high, all right? You're going to continue on this direct thrombin inhibitor until the platelet count recovers to a level above or equal to 150,000. Once you get here, if you need to continue anticoagulation, you can use warfarin or direct oral anticoagulants such as apixaban.